Welcome to the deep dive. We're jumping right in today to unpack a topic that touches the lives of, well, 100% of people with ovaries.
Mm,
The transition to menopause.
right.
It feels like this natural biological process
Yeah,
is finally and deservedly getting some significant attention.
absolutely. It's a phase that's historically been poorly understood and often, inadequately addressed. Today's deep dive pulls its insights from a comprehensive presentation by an expert who's dedicated decades to listening to women and rigorously examining the available evidence.
Exactly. Our mission is to sift through this stack of information you've shared with us, pull out the absolute most important knowledge nuggets, and really lean into the acknowledged complexity of this whole transition.
Mm,
And let's put this up front. While one hormone gets a lot of the spotlight, this isn't just about estrogen.
couldn't agree more. So where do we start? Let's define terms, maybe, because
Mhm.
even the word menopause can mean different things. Technically, in the medical sense, menopause is defined retrospectively. It's the final menstrual period, confirmed only after you've gone a full year without one.
Ah, okay. So you don't actually know you're in menopause until you're looking back at it.
Pretty much,
But what's
yeah.
happening physically for that to occur?
Physiologically, the ovaries are, well, stopping their main job of producing eggs, and critically for this transition, they significantly reduce their production of estrogen and progesterone.
Right.
This leads to low levels of those hormones, which signals the pituitary gland to ramp up production of follicle-stimulating hormone, or FSH, trying to stimulate the ovaries.
Trying to get them going again.
Exactly. Meanwhile, anti-Mullerian hormone, AMH, levels decline. Those are the key hormonal shifts.
Got it. That's the precise medical endpoint.
Yep.
But in everyday conversation, when people say menopause, they're usually talking about a much broader period, right?
Precisely. In the vernacular, menopause is often shorthand for the entire transition, from the peak reproductive years into the post-reproductive phase.
Everything that comes with it.
Yes, all the symptoms, all the shifts. This transition period, properly called perimenopause, can actually begin quite early for some individuals, sometimes even in their late 30s or early 40s.
So it's definitely not just a switch flipping around age 51.
Mm.
And the sources mentioned that period cycles themselves actually change leading up to this.
They do. There's interesting data, like from the long-running Trillar study, showing that menstrual cycles are naturally more irregular at the very beginning and very end of the reproductive span.
Okay.
They become more predictable in the middle years, say roughly 19 to 41. Then, as perimenopause progresses towards menopause, cycles often initially shorten.
Shorten, not get further apart.
Often shorten first, yes, before becoming more irregular and eventually stopping. It's not always that periods get farther apart right away.
That's a fascinating detail, shortening first. Okay, let's talk about the actual experience. The source material paints a picture of quite significant impact for many people.
It highlights a powerful truth. 25% to 30% of people with ovaries will experience substantial suffering during this transition.
Wow, that's a lot.
It is. These are people you know, people you work with, potentially even you listening right now. And a core insight here, often overlooked, is that the significant decline in estrogen has health effects on everyone, not just those with severe symptoms. It's a systemic shift.
A systemic shift.
Yeah.
That sounds key. Beyond the obvious, what are some of the ways this shift shows up?
Well, the source lists a really wide range of potential symptoms, and it underscores that it's a complex picture we're still fully understanding. Beyond vasomotor symptoms, that's VMS, like hot flashes and night sweats.
Right, the classic one.
Yeah. You also see irregular periods, genitourinary syndrome of menopause, or GSM. We'll definitely dive into that later.
Okay.
Significant sleep disturbance, mood changes, including depression and anxiety, cognitive changes, often described as brain fog.
Hear that one a lot.
Definitely. Weight gain, low libido, changes to hair and skin, joint pain, muscle aches, and that very common, often difficult to articulate feeling of just not feeling like myself.
That not feeling like myself.
Mhm.
Yeah, it really does sound like it affects so many different areas of life and well-being.
It truly does. The source includes a very relatable case example. A 52-year-old woman, irregular periods for 2 years, hasn't had one in 8 months now.
Okay.
She's struggling with hot flashes and night sweats, waking her multiple times a night. She's just not sleeping. Her sex drive has disappeared. She feels fundamentally different and, wants to fix her hormones.
Yeah.
It really illustrates the lived experience for many during this phase.
And that naturally brings us to menopausal hormone therapy, or MHT. The history of MHT feels, well, Complicated, like a pendulum swinging back and forth.
It's had quite the dramatic history. I mean, from widespread, sometimes even prophylactic use of estrogen in the mid-20th century
Right.
to understanding the endometrial cancer risk with estrogen only in women with a uterus, then observational studies suggesting potential benefits, and then the big one, the launch and abrupt stopping of the Women's Health Initiative, the WHI trial, back in 2002.
That WHI study. Yeah, it felt like a seismic event in the medical community
Yeah.
and, public perception too.
It absolutely was. The initial interpretation of the WHI findings highlighting risks like increased cardiovascular disease, clots, breast cancer.
Using a specific type of hormone.
Exactly, using a specific oral formulation, Prempro, which is conjugated equine estrogens plus medroxyprogesterone acetate in an older population average age 63. That interpretation led a significant chunk of clinicians to abandon MHT almost entirely.
Wow.
Yeah. And this created a vacuum in challenges that honestly persist today. The source even notes it's kind of sad that we likely won't ever replicate such an ambitious study.
So how has our understanding evolved since 2002? Has the pendulum swung back a bit?
It's much more nuanced now. Current interpretation, supported by reanalysis of WHI data and numerous observational studies since, clarifies a much more favorable benefit-to-risk ratio, particularly for younger, symptomatic women.
Younger mean
Generally those under 60 or within 10 years of their menopause onset. Observational data also suggests potential differences in safety profiles between transdermal through the skin versus oral estrogen,
Good.
and between micronized progesterone versus synthetic progestogens. But despite this clear understanding of benefits for many who qualify, paradoxically, few symptomatic women who would benefit from MHT actually receive it for their vasomotor symptoms.
That's a huge gap. So many could potentially feel better but aren't getting treatment. If a clinician is considering MHT today, what are the guiding principles from the source?
The core principle is rigorous individualization. You absolutely have to tailor treatment based on a woman's specific symptoms, her concerns, medical history, her unique risks.
Makes sense.
The source suggests a starting point, often initiating with one hormone, typically estrogen, then maybe considering adding progesterone roughly 12 weeks later if she still has her uterus. And crucially, starting slow, low dose.
Lowest effective dose. Can you give examples?
Yeah, the source suggests things like a 0.025 milligram per 24-hour estradiol patch, or maybe 0.5 milligrams of oral estradiol daily. Really low starting points.
And setting expectations is important too, I imagine.
Vital. MHT can take 10 to 12 weeks to really see the full effect. And it's often an iterative process adjusting the dose, maybe the type, to find what works best for that individual.
And you mentioned transdermal patches. Why are they often highlighted as a preferred route?
Well, transdermal delivery patches, gels, sprays bypasses the liver's first pass metabolism that happens when you swallow a pill.
Okay, what does that mean practically?
It results in more stable estrogen levels in the bloodstream, and it might have a different impact on liver-produced factors like clotting factors, although, rigorous comparative outcome data isn't always abundant.
Interesting.
Plus, a single drug patch can often be physically cut, allowing for even more individualized microdosing or taping later on. The source even mentions one study suggesting transdermal modestly improves sexual function compared to oral CEE. Another interesting point.
Are there practical tips for using patches, like where to put them, dealing with skin irritation?
Yeah, the source suggests placement on the thigh, abdomen, or buttocks. Applying to the buttocks can actually lead to about 20% better absorption for some people.
Oh, interesting.
If irritation occurs, sometimes switching from a weekly patch to a twice-weekly one can help. Or using a tiny bit of topical steroid cream, like fluticasone or hydrocortisone, under the patch adhesive.
Right.
For individuals where absorption seems poor, maybe checking hormone levels could be considered, but again, routine testing isn't standard practice. And yes, you can cut the patches for dose adjustment or tapering.
Are there other transdermal options besides patches? Sprays, gels?
Yes, absolutely. The source lists estrogen sprays like Evamist, gels such as Divigel or Estrogel, and even vaginal rings like Femring, which provide systemic absorption, not just local. Pellets are also mentioned as another delivery method.
Now, a critical point you touched on.
Yeah.
If someone still has a uterus, progesterone is necessary alongside estrogen. Why is that so important?
That's non-negotiable, really. If you have a uterus, you need a progestogen to protect the endometrium that's the lining of the uterus.
Protected from what?
Unopposed estrogen without progesterone significantly increases the risk of endometrial hyperplasia, which is an overgrowth of the lining that can become cancerous. So progestogen is essential for safety.
Got it. What are the options for adding that progesterone?
You can use progestogen cyclically, typically for 12 to 14 days each month, which usually results in a monthly bleed. Or you can use them continuously every single day,
And the goal with continuous is?
usually to achieve no bleeding at all eventually, though it's very common to have irregular spotting or bleeding during the first 4 to 6 months as your body adjusts.
Okay. And how much progesterone is needed? Is that well established?
Surprisingly, data on the exact necessary dose to ensure endometrial protection is quite limited. The source lists common types and doses, like medroxyprogesterone acetate, norethindrone, and micronized progesterone.
Micronized progesterone.
Yeah.
That one comes up a lot.
It's often favored, yes, though some women find it gives them side effects, kind of like PMS in a bottle. Others actually report it feels sedating or can help with anxiety, so finding the right type and regimen is often a process of trial and error.
And the source notes, it's important to minimize the progestogen dose.
Yes, because while it's complex, progestogen exposure could potentially contribute to breast cancer risk, whereas estrogen alone seems to have a different, perhaps more favorable profile in that regard. Minimizing the dose while still ensuring endometrial protection is key.
Okay, let's dive deeper into the risks because this is where so much of the public concern around MHT stems from, understandably, given that WHI history. How should we frame the discussion around MHT risks?
The source suggests thinking about risk in two main ways. First, the overall risk profile of MHT itself. Second, how an individual woman's unique health profile, her background risks, alters that equation specifically for her.
So it's personalized.
Absolutely. Which leads to the mandatory component of MHT prescribing, shared decision-making.
Yeah.
It has to be a conversation between the clinician and the patient.
Especially since there are still gray areas, right?
Exactly. There are still areas with limited or no definitive data. And it's worth reemphasizing that the WHI trial, while important, is often misunderstood. The age of the participants, the specific oral formulation used, the delivery route, those all matter significantly when interpreting its findings for, say, a 52-year-old today.
Let's tackle specific risks then. Heart disease is mentioned in the source as a tangled yarn. Why so complex?
It's tangled because menopause itself, the loss of estrogen, leads to unfavorable metabolic changes over time, which can increase cardiovascular risk anyway.
Okay.
The original WHI did show an increased risk of CVD events with that specific Prempro formulation. However, our understanding has evolved quite a bit.
How so?
It's now thought that the specific formulation, the delivery route, oral versus transdermal, a woman's age when starting MHT, and how long it's been since her last period likely all influence the impact on cardiovascular outcomes.
But we don't have perfect head-to-head data comparing all those.
Rigorous data comparing all those variables is still lacking, unfortunately. Interestingly, though, the source references the recent International Menopause Society white paper from September 2024,
Yeah.
which states there's actually good data supporting its use for reducing the risk of CVD, a contrasting viewpoint to the initial WHI reaction, particularly for younger women starting therapy.
That is a contrast.
And furthermore, the source notes that vasomotor symptoms themselves, especially if they're severe, are increasingly associated with increased cardiac risk down the line, so treating the symptoms might even be beneficial for heart health. It's complex.
Definitely nuanced. What about blood clots, thromboembolic disease?
Right. The WHI remains the only large randomized controlled trial that showed a significant increase in these events, specifically with oral estrogen.
Only with oral.
Yes. Observational studies and a meta-analysis cited by the source, pooling 15 studies, strongly suggest a higher risk of venous thromboembolism, VTE, including deep vein thrombosis, DVT, with oral versus non-oral hormone therapy.
What kind of increased risk are we talking?
The relative risk for VTE is about 1.63, and for DVT about 2.09 with oral versus non-oral. Because of this, current guidelines tentatively favor transdermal estrogen as potentially safer regarding clot risk, acknowledging, of course, that observational data isn't the highest level of evidence.
Okay. And breast cancer, arguably the biggest fear for many women considering MHT.
It's a major concern, absolutely. And the source states the relationship directly. Estrogen exposure is related to breast cancer risk. It lists several risk factors. Weight, having a BMI over 25.
Okay.
The total duration of estrogen exposure throughout life, both your own natural estrogen and any external hormones, risk increases slightly, about 1.027% per year of exposure. Alcohol use is a factor. Early menarche, having your first period young. Obesity. and late menopause.
And those last three, early menarche, obesity, late menopause, they increase your exposure to your body's own estrogen, right?
Exactly. They increase the time your body is naturally exposed to higher estrogen levels.
The source provides some specific numbers regarding extra breast cancer cases. Can you share those? They help put it in perspective.
Yes, they do. These numbers are for average weight women starting MHT at age 50, looking at the extra risk over 5 years of use, for continuous estrogen plus progestogen therapy, EPT.
So for women with a uterus.
Right. The increase is roughly 1 extra case of breast cancer in 50 users over those 5 years. For cyclic EPT, it's slightly lower, 1 extra case in 70 users.
And for women without a uterus using estrogen alone.
For estrogen alone therapy, ET, the risk is significantly lower, 1 extra case in 200 users over 5 years. It's important to note these figures are for average weight women in developed countries, and the background risk of breast cancer increases with age anyway.
So it's definitely not zero risk, but understanding those specific numbers and the context, especially the difference between EPT and ET, is crucial.
Absolutely. It's all about having that informed conversation, weighing those potential risks against the potential benefits for that individual.
And speaking of benefits, let's shift gears. The source includes some really powerful quotes from women who are using MHT and describe themselves as happy people. What's the upside? What are they experiencing?
The upside is the profound impact MHT can have on quality of life for many women who are really struggling with symptoms.
Yeah.
The quotes from the source really highlight this. Getting a good night's sleep finally, feeling like they have their brain back, partners noticing a positive difference, the near elimination of debilitating hot flashes, and that powerful feeling of being like myself again. For the right individual, MHT can truly alleviate significant suffering and restore that sense of well-being.
Which leads right into the next big question.
Yeah.
How long should someone stay on MHT? Is there a recommended age to stop? The advice seems to have changed.
It really has. This is a key point where guidance has shifted. The North American Menopause Society, an AMS position from 2022, is quite clear. Applying an arbitrary age-based stopping rule is not clinically appropriate.
So forget the old idea that you just stop at 60 or 65.
Pretty much. Because bothersome VMS and other symptoms can persist for many, many years for some women, well into older age.
Okay. And is there any research looking at potential benefits of staying on longer?
Yes, there's an interesting study mentioned in the source, Bake et al., 2024, which hints at the possibility of important health benefits extending beyond age 65, particularly depending on the type and route of MHT.
Like what kind of benefits?
For women without a uterus using estrogen alone therapy, ET, continued use seemed associated with reduced risks of all-cause mortality, certain cancers, heart failure, VTE, atrial fibrillation, heart attack, and potentially even dementia.
Wow, that's significant. What about for women with a uterus using EPT?
For EPT users, the benefits seem less clear-cut in that study, and it does increase breast cancer risk with longer duration. Although, again, lower doses and transdermal or vaginal routes with progestin might mitigate this. The risk reduction seemed greater with lower doses, non-oral routes, and using estradiol rather than CEE.
So it's not just about symptom relief anymore. There might be longer-term health implications, positive or negative, that are still being explored, challenging that hard stop date idea.
Exactly. It's becoming a much more individualized discussion about long-term use.
What if someone does decide to stop MHT? Is it better to taper off slowly or just stop abruptly?
Well, the data on tapering is actually quite limited, as the source notes. One observational study showed about a quarter of women resumed MHT within 6 months after stopping, regardless of how they stopped. A small study found no difference in symptom return between tapering on alternate days versus daily. Another comparing a 6-month taper to stopping cold turkey also showed similar resumption rates, around 37% versus 42%.
So the evidence isn't clear-cut on tapering being better.
Not definitively from those studies. The practical advice from an experienced clinician cited in the source is really to individualize the approach. Maybe have the conversation around age 60, and if tapering, do it slowly.
How slowly?
Like cutting a quarter of a patch off, or reducing an oral dose just a couple of days a week. Ideally with a minimum 3-month tapering period, always aiming for the lowest tolerable dose needed for symptom relief if continuing.
Okay. This brings to mind the case example from the source. The 68-year-old who's been on MHT since age 47 after a hysterectomy and wants to continue. She's also asking about bioidentical hormones and testing her blood levels. Common questions, I bet.
A very common scenario. Patients hear a lot about bioidentical hormones. These are simply hormone preparations that are molecularly identical to the hormones your body naturally produces, like estradiol, progesterone, testosterone.
Okay.
They can be FDA-approved products, or they can be custom compounded formulations from specialty pharmacies. They're often marketed with the implication that they are somehow safer or more natural than synthetic
Is
hormones.
that true? Are they safer?
There's no good evidence that compounded bioidenticals are safer or more effective than FDA-approved versions. And it's worth noting there are FDA-approved options that are bioidentical, like micronized progesterone and various estradiol preparations. Prescribing compounded versions often involves frequent hormone level testing too.
Right. The blood testing. The source had a very vivid quote about that. Why isn't routine testing usually recommended?
Yes, this is a crucial point the source really hammers home. Routine blood testing of estradiol or progesterone levels is not generally indicated, especially during the perimenopausal transition when hormones are fluctuating wildly day to day, even hour to hour.
Mm.
The quote from Dr. Brian Walsh perfectly captures it. Doing hormone levels on a perimenopausal woman is like taking a picture of the speedometer when the car's in the garage. You have no idea what's happening 10 minutes before or what will happen 10 minutes later.
Huh. That analogy really hits home. It sounds like chasing a moving target during perimenopause.
Exactly. It's just not a reliable snapshot of what's going on overall during that chaotic phase. And the source points out that women are often subjected to a lot of confusing information out there, and unnecessary hormone testing can just add to that confusion if not interpreted very carefully.
Let's zero in on perimenopause then.
Yeah.
It sounds like that phase, even before menopause is official, is a particularly chaotic time. The source describes its definition as murky and even a vibe.
A vibe is pretty apt, actually. Perimenopause is that transitional phase leading up to menopause, and it's defined by those unpredictable hormone swings. It can last anywhere from 4 to 8 years, sometimes longer,
And the hormones are just all over the place.
wildly fluctuating. Estrogen can actually surge to levels higher than ever before sometimes, while progesterone production, which normally happens after ovulation, starts to become less predictable as ovulation gets less regular. Attenuating is the technical term.
And the data shared in the source about when symptoms start was really eye-opening for me.
It was, wasn't it? The striking insight there is that for many women, symptoms often begin before their menstrual cycles become noticeably irregular.
Really?
Yeah. In a survey of women who still had pretty regular cycles or only minimal changes, 40% or more reported experiencing things like night sweats or cold sweats, feeling easily overwhelmed, urinary leakage, waking at night, and having trouble falling back asleep. Dry skin, anxiety, fatigue, difficulty concentrating, that brain fog again, breast tenderness, low libido, irritability, and forgetfulness, all before major cycle changes.
Wow. So many of those classic menopause symptoms can actually start years earlier when you might not even suspect perimenopause because your periods are still fairly regular. That fundamentally changes how you might approach those symptoms.
It really does. It reinforces the point that symptoms in the late reproductive stage and the full menopausal transition are often more similar than they are different. It truly is, as the source puts it, a chaotic hormone tale during this period.
Given that hormonal chaos, is there any test that can definitively predict when menopause will actually happen, when that final period will be?
Unfortunately, no. The source states clearly that no test can predict menopause with certainty. The best predictor remains age itself, with the average age being around 51, 52 in developed countries.
Does family history play a role, like your mother's age?
There's some influence from the age your own mother went through menopause, yes. But it's not perfectly predictive. AMH levels offer information and show some promise, particularly combined with age, for predicting the likelihood of reaching the final menstrual period within, say, 12 or 36 months.
But not a guarantee.
Not a crystal ball, no. And interpreting AMH levels presents its own challenges. Other indicators, like measuring progesterone metabolites like pregnenolone are showing promise in research but aren't widely used for prediction clinically yet.
So the menstrual cycle itself, as a vital sign, really is still the most reliable indicator of where you are in the transition, generally speaking.
Precisely. It's often the first signal that hormonal shifts are underway, even if those noticeable cycle changes sometimes lag behind the onset of other symptoms, as we just discussed.
For managing symptoms during the perimenopausal phase itself, when maybe full MHT isn't yet the primary approach or is being introduced later, what are the therapeutic options mentioned in the source?
Well, beyond potential MHT use later in the transition, the initial approaches often involve validation, Just acknowledging and validating that these experiences are real and hormone-related is hugely important for women.
Absolutely.
Then, it's often about treating specific symptoms individually. For hormone options during perimenopause specifically, the source mentions things like continuous active oral contraceptive pills, OCP.
Birth control pills.
Right. Although the source does raise some questions about the rationale for continuous use versus cyclic, when exactly to stop them, and using them long-term into the typical menopause years. Micronized progesterone is another option mentioned, as some studies show it can help with perimenopausal night sweats and hot flashes even before cycles are completely irregular.
Okay. Let's briefly touch on premature ovarian insufficiency, or POI, and early menopause. These sound like special cases that need different consideration.
They absolutely are and require distinct management. Women who experience POI, that's menopause before age 40 or early natural menopause before age 45, or who go through surgical menopause from ovary removal or chemotherapy-induced menopause, they need systemic estrogen therapy.
Needed. More strongly than women going through menopause at the average age.
Yes, and often in higher doses than typically used for standard MHT in older women. It's primarily for long-term health protection.
Protection against what?
Specifically bone density loss, cardiovascular health risks, and potentially cognitive function decline. These women have lost the protective effects of their ovarian hormones much, much earlier than average.
So what's the recommendation?
The recommendation, supported by a comprehensive guideline on POI from late 2024 mentioned in the source, is generally to provide MHT or sometimes COCs, though COCs may have a different risk profile to consider until at least the average age of natural menopause, so around 51 or 52.
Okay, that's a really important distinction for those individuals. Moving on to another very common and impactful issue mentioned, genitourinary syndrome of menopause, or GSM. The source uses a case example of a 55-year-old woman experiencing discomfort during a pelvic exam and painful sex.
This is a hugely prevalent issue. It used to be called vulvar vaginal atrophy, and it affects a vast number of postmenopausal women. It significantly impacts quality of life and intimacy.
And GSM describes.
It describes the changes to the vulvar, vaginal, and lower urinary tract tissues like the bladder and urethra due to the loss of estrogen. This leads to symptoms like dryness, itching, burning, painful sex, that's dyspareunia, and also urinary symptoms like urgency, frequency, and recurrent UTIs.
Sounds really unpleasant. The source outlines a practical step-by-step treatment approach.
Yes, it does. It starts with anticipatory guidance, just letting women know this is common and treatable is the first step.
Okay, then what?
Then recommending basic measures. Lubricants, and maybe even vegetable oils during sexual activity. And non-hormonal vaginal moisturizers used regularly, like a few times a week, not just during sex, to improve overall tissue health.
And if those aren't enough?
If those aren't sufficient, the next crucial step is usually local estrogen therapy.
Local estrogen.
Mhm.
How is that different from the systemic MHT we were talking about earlier?
Local estrogen is delivered directly to the vaginal and vulvar tissues. It comes in creams, tablets, or rings that are inserted vaginally. While some minimal systemic absorption can occur, it's generally much, much lower than with standard systemic MHT pills or patches.
And is it effective? Safe.
Highly effective for GSM symptoms. And the source highlights that local estrogen is considered likely safe even in most breast cancer survivors for whom systemic MHT might be contraindicated. Though obviously data on specific products in individual cases should always be considered carefully.
Are there different local estrogen products available?
Yes, the source lists various options. There are vaginal rings like Estring, creams like Estrace or Premarin, and small tablets or inserts like Vagifem or Imvexi. Each has different pros and cons regarding cost, dosing regimen, maybe slight differences in systemic absorption, though usually very low.
And are there other steps if local estrogen isn't the answer or isn't enough?
Yes, the GSM treatment algorithm also includes things like pelvic floor physical therapy, using vaginal dilators or vibrators to help maintain tissue elasticity, sometimes topical lidocaine for immediate pain relief during intercourse, and even considering outer course forms of intimacy that don't involve penetration.
So local estrogen is a powerful tool specifically for GSM, often a separate decision from systemic MHT. Let's pivot back to systemic MHT for a moment. Is it ever appropriate to use MHT purely for prevention, not just for symptom relief? like for bones or heart health.
Right. The source addresses this using the case of a 49-year-old woman. She has mild perimenopausal symptoms, but is
Hmm.
primarily interested in MHT specifically to prevent bone loss, heart disease, and dementia.
What's the evidence regarding bone health prevention with MHT? That seems like the strongest case.
It is the area where prevention has the strongest support. MHT does effectively work for maintaining bone density and preventing bone loss, and it is FDA approved specifically for the prevention of postmenopausal osteoporosis.
So should all women consider it for bone health?
The official NAMS position suggests considering MHT solely for osteoporosis prevention only in women who are at significant risk of osteoporosis, or maybe when other non-estrogen bone medications aren't suitable for them.
But the WHI data showed fracture reduction.
Yes, the WHI data cited clearly showed MHT significantly reduced the risk of all fractures, clinical fractures, major osteoporotic fractures, and importantly, hip fractures.
So there's some tension there.
A bit. The source notes that, Dr. Google is all in on this benefit. Women are rightly concerned about osteoporosis, and there is support within the medical community for evaluating women at menopause, particularly those with risk factors.
Like low weight, family history.
Right. Low weight, family history of hip fracture, being a smoker, long-term steroid use, high alcohol intake. Evaluating these women, and perhaps even considering MHT for treating osteopenia, which is low bone mass before it reaches osteoporosis. There's even a suggestion that MHT's role in osteoporosis prevention might get stronger in future guidelines.
So bones seem like a clear case where prevention with MHT is supported, at least for specific populations or those who also have symptoms. What about using MHT solely for preventing heart disease or dementia?
Based on the current evidence laid out in the source, using MHT solely for the primary prevention of heart disease and dementia is still considered TBD to be determined, meaning the data just isn't strong enough yet to recommend starting MHT only for those reasons, in the absence of bothersome menopausal symptoms.
Okay. Let's talk about testosterone for women. It feels like interest in this is really growing, and it's often presented as some kind of panacea for energy, libido, brain fog.
Yes, there's a lot of interest and maybe some hype, but it's crucial to be really clear about the evidence presented in the source. In the U.S., testosterone for women is primarily prescribed off-label, meaning not FDA approved for this use, mostly for sexual complaints. The source states there are no clearly established indications for testosterone therapy for women, except for one specific condition.
And levels do decline with age.
They do. Testosterone levels in women decline significantly with age by about 55% between ages 18 and 62. However, a key point. Levels are notoriously difficult to measure reliably in women, and low blood levels do not reliably correlate with measures of sexual function or well-being in women.
Okay, so a low number doesn't automatically mean you need testosterone.
Right.
What is that one specific condition where it might be indicated?
Hypoactive sexual desire disorder, or HSDD.
HSDD. Define that for us.
It's defined as a persistent or recurrent deficiency or absence of sexual fantasies or thoughts and/or desire for sexual activity, which causes marked personal distress or interpersonal difficulty.
So the key is the distress it causes, not just having a lower libido than before.
Exactly. It's not just low libido. It's low libido that is genuinely bothersome and distressing to the woman herself.
And the source emphasizes the brain's role in female sexual function.
Absolutely. It points out that the most important sex organ for women is, arguably, the brain. Addressing HSDD requires a comprehensive, multi-pronged approach. You have to consider contributing factors like other medications, relationship issues, psychological factors like depression or anxiety, and definitely addressing any painful sex dyspareunia, which brings us back to treating GSM potentially.
So testosterone isn't the first or only step for HSDD. But if it is being considered, what does the source suggest as a practical approach?
The suggested approach is, first, get a baseline testosterone level, mainly to rule out any underlying medical issue causing unexpectedly high levels. Then, if proceeding, use a male FDA-approved product, but at about 110th of the typical male dose.
1/10. Because there aren't female-specific products in the U.S.
Correct. There are no FDA-approved female testosterone products currently available in the U.S. Follow-up levels should then be checked 3-6 weeks after starting, and then maybe every 6-12 months, just to ensure levels stay within the normal physiological range for women.
And how long does it take to work?
This is important. It can take up to 4 months to see any effect on desire. And if there's no noticeable benefit after about 6 months, the recommendation is to stop using it for HSDD. It's not something to just stay on indefinitely if it's not helping.
That sounds like a very specific, targeted, and cautious approach, not a blanket fix at all. And is there any evidence to support testosterone use for other common complaints like energy, mood, or cognitive function?
The source is exceptionally clear on this point based on the available evidence from rigorous trials.
Okay.
It states unequivocally that the available evidence does not support the use of testosterone for women of any age for the prevention or treatment of cardiovascular disease, depressive symptoms, cognitive performance or decline like brain fog, muscle loss, bone loss, osteopenia, osteoporosis, or any other disease or condition, other than HSDD.
Other than potentially for postmenopausal HSTD causing distress. While safety data on short-term use, maybe up to 2 years, seems generally reassuring, long-term use beyond that remains a no-data zone based on good clinical trials.
So, highly specific indication, careful monitoring, limited long-term data.
Precisely. It might play a larger role or be considered more strongly in cases of surgical or early menopause, where androgen levels drop more abruptly, but the broad panacea-like claims often made are just not supported by the current scientific evidence.
Okay, that's very clear. Beyond hormones entirely, what about non-hormonal options? Specifically for managing those troublesome vasomotor symptoms, the hot flashes and night sweats.
Right. For women who can't take hormones, or prefer not to, there are evidence-backed non-hormonal options. The source provides a list of recommended treatments, categorized by their evidence level.
What's on the recommended list? These include behavioral therapies like cognitive behavioral therapy, CBT, and clinical hypnosis. Certain pharmaceutical options like specific SSRI and SNRI antidepressants, low doses often used, gabapentin, the newer drug fezolinetant, which we can discuss more, and sometimes oxybutynin, typically used for bladder issues but can help VMS.
Any lifestyle things.
Weight loss, if overweight or obese, can definitely help reduce VMS. And surprisingly, stellate ganglion block, which is actually an injection procedure near the neck, is listed as a recommended option with good evidence for severe VMS.
Interesting. And are there non-hormonal things often tried that the source indicates aren't recommended or lack strong evidence, things people might buy over the counter?
Yes, the source contrasts the recommended list with things that have limited or insufficient evidence, or are specifically not recommended based on current data. This includes things like paced respiration alone, many over-the-counter supplements, and herbal remedies.
Like black cohosh,
Yeah.
soy.
Evidence is often mixed or low quality for many of these, like black cohosh. Soy isoflavones have some weak data, but generally aren't strongly recommended. The source advises caution due to lack of regulation and robust data for many supplements. Also on the not recommended or limited evidence list are general exercise alone, great for health but not proven for VMS specifically. Yoga, mindfulness, or relaxation techniques alone, again, good for stress but direct VMS impact unclear. Acupuncture, chiropractic interventions, an older blood pressure med called clonidine, general dietary modification, and another nerve medication, pregabalin.
Okay. You mentioned fezolinetant. That's a newer name. Many listeners might have heard. Vazoza is the brand name. How does that one work, and who is it for?
Right, fezolinetant or Veoza. It's a specific type of drug called a neurokinin 3 or NK3 receptor antagonist.
NK3. What did that mean?
These NK3 receptors are involved in the brain's thermoregulatory center in the hypothalamus, basically. They play a role in the signaling pathway that triggers hot flashes. By blocking these specific receptors, fezolinetant can reduce the frequency and severity of VMS.
Who is it indicated for?
It's indicated for moderate to severe menopausal vasomotor symptoms. Studies have primarily been in women aged about 45 to 65. It does have some contraindications, including certain liver conditions, and the FDA requires baseline and follow-up liver function tests because of a small risk of liver enzyme elevation.
Any side effects? Cost?
Common side effects can include abdominal pain, diarrhea, insomnia, back pain, and those elevated liver function tests, LFTs. And yes, the source notes its relatively high cost, around $588 a month currently, which can be a barrier.
So a targeted non-hormonal option acting on the brain's temperature control, but with monitoring needed and cost considerations. And another one, elinzanetant, is mentioned as coming soon.
Yes, elinzanetant is another promising non-hormonal option currently in late-stage development. It's slightly different. It's a dual neurokinin 1 and 3 NK1/3 receptor antagonist.
Full action.
Right. Clinical trials have shown significant reductions in both VMS frequency and severity compared to placebo. And interestingly, studies also showed improvements in sleep disturbance and overall menopause-related quality of life. so potentially hitting VMS and sleep issues.
It sounds like non-hormonal pharmaceutical options are definitely an active area of development, which is great news for providing choices.
It really is. Having more safe and effective options available for women who cannot or prefer not to use hormones is absolutely critical.
Okay, to wrap things up and consolidate for the listener, what are the absolute key takeaways? The vital pieces of information the source suggests should be shared with women as anticipatory guidance about this whole transition.
The critical points to communicate are: this transition can start earlier than many women anticipate, often in the late 30s or early 40s. Every woman's individual experience, her script, is unique. There are no tests that can predict with certainty exactly when you will become menopausal. The first sign of hormonal shifts is often cycles getting closer together initially, not necessarily further apart. Menopause and perimenopause are much, much more than just hot flashes and vaginal dryness. They affect nearly every system in the body.
Okay.
Weight gain during this phase is common and complex, tied to metabolic shifts as well as habits. Mood and cognitive effects like anxiety, irritability, and brain fog are real experiences rooted in hormonal changes.
And important.
And a very positive takeaway is that most women report feeling significantly better after they fully complete the transition. They get through it. Finally, this period is a crucial time to assess individual risk factors for major long-term health issues like breast cancer, heart disease, and osteoporosis, and make proactive health choices.
That's a really helpful consolidation. It feels like even with all this research, though, there are still fundamental questions where we just need more data, right?
Absolutely. The source points to what it calls the tyranny of evidence-based medicine, meaning the reality that even with the best intentions, there are key questions where the data is still limited or conflicting.
What are some examples?
Areas needing more research include things like pinning down the minimal effective progestogen dose for endometrial protection, getting more specifics on breast cancer risk tied to MHT dose, duration, route, and genetics, definitively clarifying the VTE risk of transdermal estrogen compared to oral with large trials, understanding the optimal hormonal approach like COCs versus MHT for women with POI, and getting more long-term safety data beyond a few years for testosterone therapy in women. It just underscores that the science is continually evolving.
So if you were to give the super high-level summary, the core message to someone who maybe zoned out for a few minutes during our deep dive, what are the absolute must-knows?
Okay, the source's summary points are excellent for this. First, educate yourself and others about menopause. It happens to everyone with ovaries, and everyone's experience is an individual script. Don't assume yours will be like someone else's.
Right.
Second, recognize that perimenopause is a complex, often confusing period. The source's evocative phrase was, "What fresh hell is this?" Third, MHT is not poison. It can be a life-changing tool for significantly improving quality of life for many symptomatic women when used appropriately. Fourth, the correlation and significance of hormone levels are still being figured out, and routine testing is typically not needed or helpful, especially in perimenopause.
Okay, two more.
Fifth, MHT is not categorically indicated today solely for prevention of chronic diseases, with the possible exception of bone health in specific high-risk individuals. And finally, based on current evidence, testosterone therapy is appropriate only for postmenopausal HSDD causing distress, and not for other conditions like boosting mood, energy, or cognition.
That's an incredibly comprehensive picture, really drawing out the nuances and the key actionable insights from this material. Thank you so much for guiding us through this complex but vitally important topic.
It's my pleasure. This information really has the potential to truly empower women navigating this significant stage of life.
And if you, the listener, want to continue learning, the source points to some excellent resources like menopause.org, that's the North American Menopause Society, also womenlivingbetter.org, and the International Menopause Society, IMS website. They have great patient resources, and they had recent white paper on menopause and MHT we mentioned.
And maybe to leave you with a final thought for reflection, this one also from the source presentation, a quote, intended to bring both humor and perhaps a little perspective.
Okay.
I was on hormone replacement for 2 years before I realized that what I really needed was Steve replacement.
Wow. Okay. That's quite the thought.
It is, and while it's clearly meant to be lighthearted, I think it contains a valuable reminder. While medical interventions like MHT are powerful and necessary tools that can address the very real physical symptoms of hormonal shifts, sometimes how we feel overall is influenced by other factors in our lives too, relationship dynamics, stress, work, other life changes. The journey through this transition is deeply personal and multifaceted. It involves biological changes, yes, but also psychological and social elements.
Whole person perspective.
Exactly. And as the source presenter hopes, perhaps with more research and understanding, the data gaps will indeed be slimmer and the journey smoother for future generations experiencing this universal transition.
A perfect thought to end on. Thanks again for joining us on this deep dive.